go to those slides, actually. We have the slides here. So let's imagine he has leg pain on the left. He can't walk long until his sciatica gets much worse on the left side. First thing we do is flex him forward. We flex him this way. Does that relieve his pain? He's in flexion and lateral flexion. Yes. Okay. I write that down on my charts. I would categorize that as a left lateral disc herniation. So then, if he has more pain this way, lateral flexion, he does have more leg pain, more peripheralization of the pain, more localization of the pain. Then I would flex the patient this way and back. Does that relieve the pain? No, it makes it worse. Sometimes it'll make it better because you could get medial disc on the same side of leg pain. But it doesn't matter if it's medial, lateral, who cares what the name is? Find the pain-causing position and do the opposite. Find the pain relief patient mimic, right? Just don't put them on a linear table and let's go stretch, come on. So here we have relief of pain, and this is why. When we flex this way and forward flexion, lateral flexion, we're moving the nerve root, come up, the nerve root away from the laterally located herniated disc. Okay. Pain down the right leg, it's opposite from him. He's pain down the right leg, moving this way, and forward flexion reduces his pain. That's a medial disc. So then I would put it in a position, if it was a flexion distraction device, I would move into the right, to the left lateral position, in this case. I would copy that patient's posture, and if I didn't see the posture, I would test it. If it wasn't obvious, he didn't come in standing like this, right, leg pain down the right side, he comes in like this, doc, I don't feel well. I could follow it, but if I don't see it, it's occult. It's an occult situation, and I have to really challenge him on which is the position that aggravates it and do the opposite. So here we have right lateral flexion, forward bending, produce relief on this patient, left lateral pain, leg pain. And the central disc, great for those tables that are linear. The multi-directional decompression devices, keep them axial, pull them linearly. There's no lateral component. You just want to retract the disc. And you may try to use intermittent, motorized, or constant, and change and vary your force. It's trial and error. It's an art. Traction is an art. Forward flexion, most of the time relief. 20% of the cases, relief in extensions. You put in the extensions. Do you find that a lot? So here we have a medially situated disc. Right? It's medial to the nerve root, descending nerve root. It's going down the leg on the same side. So his shift is towards the same side of pain. Doesn't matter if it's medial or lateral. This is the position. In this case, it is medial. And this is the position we're going to stretch him in. He may also equally be stretched in this way, in extension. The lumbar support extended. Because this may be his pain relieving position, for his particular lesion, whatever is going on there, right? And then, of course, the extension in this patient with left leg pain, radiating pain, and stenosis doesn't allow a normal lordotic curve to develop. There's spasm, restriction of motion, and according to chiropractic palpation, when there's restriction, there's subluxation, correct? Could you run the tape, please? So I teach these techniques as standardized ways of classifying what you're treating and the disease. This is a film from Lebanon, a wonderful physical therapist who's using the device, and she's doing a provocative M3D range of motion. Right lateral flexion to relieve pain or increase the pain of the rest of the patient. We're going to classify what it is and then position the patient on the traction table in that position if possible. She's a wonderful, caring physical therapist. This is very, very interesting in preparing for this. Yes, sir?
3 minutes.
Well, 3 minutes? For what? Half an hour. Okay. This is something that, in preparing for this lecture, I thought was great because I developed all of this testing I've been doing for years with patients to isolate, find out what area, and do the opposite, pain relief. Do the pain relief position or mimic when you treat. Here's physical therapists that want to see during their clinical examination periods whether axial stretching has any effect or decrease on their pain. So they laterally flex, and then they give a little lift. And that, in most of the cases, on the cases that they had, 70 patients, 20 of 20 would have relief either right lateral flexion, left lateral flexion. You could even lay the patient down and see if axial flexion helps. Here the physical therapists are classifying and seeing the contribution of axial distraction to chronic pain in this definition. So we can do this when we examine the patient as part of our examination. And then we can say that patient, we find out what position is pain relieving, put them in that position mimicking, whether axial decompression will help at all. Likely to help. Even having a patient do this, does that relieve your pain? I thought this is ingenious. Does that relieve your pain? They may be a candidate, in addition to manipulation, adjustments to this. Now, I adjust my patients when they need it. I'm going to get into that. How about, does your patient need a back support? A little bit of pressure, they lean back, try to relax, relieve their chronic pain. Maybe you can suggest a back support in a car or car seat. Maybe during distraction procedures, you may want to elevate your lumbar section. Because this patient may benefit from more support, more extension decompression. This is the study that goes along with that. 21 of 20 patients, 100% showed improvement. 16 of 20 in improvement right or left flexion, laying down, significant improvement. Conclusions: these tests are a quick and effective way to assess the contribution of axial decompression on low back pain and potentially used as part of the plan of care. So we're taking it one step further. We've identified it, and now we've put the patient in that position to begin to axial stretch them. This is just a graphic of what happens when you have a lateral disc hitting the L5 nerve root, L4 disc, L5 nerve root, and the very act of moving away is theoretically reducing the size of the herniation with a contact, the area of contact between the nerve root, descending nerve root, the lateral recess, and the degree of contact. And we're going to show you a little graphic that I have made, which I thought was great. See if you think so. Let's advance this. Can you run the slide, please? So stretch them linearly when you didn't do your testing. Run it again, please. Worse. More contact. So first you want to move the patient into the pain relieving position that you've identified, if there is one. If not, just go according to the literature, clinical experience, trial and error, what helps that patient. Maybe flexion, maybe extension, maybe lateral positioning on the decompression table and put them in that position. But clearly, when there's a lateral disc or medial disc, they come in this way, and you're acute, you want to treat the patient right away, you get immediate results. And you don't want to get the patient worse, right? You don't want to drive that nerve more into the disc. First, you want to create the space, move the disc, the nerve away from the disc, and then stretch, right? That's the whole object, right? Then start the cyclical forces or whatever, whether it's mobilized or manually administered. When to absolutely avoid using linear axial decompression. When am I not going to put a patient in linear decompression? Does anyone know the answer to that? If you know the answer to that, you automatically get a free cup of coffee at Starbucks from me.
Prolapse?
Let's skim milk. When you've done it, go ahead. That's it. You get a cup of Starbucks coffee. Beautiful. So when you clearly see that the linear position increases pain, then you want to put him in what position?
I was going to say, is it sometimes when you take the disc off the nerve root, there's like a affirmation to that's a pseudo pain that's good for you? I mean, not a pseudo pain, but a pain that you have to take in order to relieve the disc pressure?
Patients have more pain sometimes initially after you stretch them. But I've used this analysis and the classification of patients, and this has been an evolving process for 30 years. And I have no lawsuits because, and there's no, in the FDA MORD reporting for injuries related to disc herniations and treatment of patients, there's never been an injury on Extentrac.
One other question.
Because you're positioning the patient correctly.
Is there any modification of the technique when you have asymmetrical facets where when you're going to do the bending, it's not going to go where you want it to go?
I suppose there is. Hasn't stopped me from treating the patient. Good question. I don't know how to answer it. Okay, so what do I tell my patients that I'm doing when they come in? What is the focus of what we're doing really for traction? What does the research show? This is an old study, but it's a good one to know. And this is 12 patients. They put these patients into CAT scans, post-myelogram CAT scan, and they put them in flexion and extension. And they saw what it did to the cross-sectional area of the fecal sac. So my object when a patient comes into me with disc herniation and disc pain is to open up the canal. So when the patient places in my hand their MRIs, their X-ray reports, all of their things that I read, and you see all of the various stenoses, facet hypertrophy, foraminal encroachment, lateral recess encroachment, degenerative joint disease, narrowing of discs, spondylolisthesis. As long as it's not stable, it's not one of the contraindications of using traction or decompression with the patient. Then my object is to tell a patient, I'm going to take all of this stuff, and my object is to open up your canal. I'm going to do a non-surgical procedure on you that is as effective as a surgical implant that's going to space go an exile. It may take 5 to 10 times. Most of my patients and protocols I teach, 10 visits, and you've got most of your stenosis patients cured. The only thing you can cure is a hand, I know. So in these patients with facet hypertrophy, interesting phenomena occur. We'll look at the anatomy a little bit here. We have the cross-sectional area of the spinal canal. This is the key area that I look at. When I look at an MRI, immediately the patient brings in the MRI, disc herniation, pain, or stenosis, or degeneration, they can't walk. Immediately, I'm looking here. This space here, the anterior lateral recess. Is this closed up? Are the facets hypertrophy and pushing up and making the fecal sac smaller? Now, if I don't make the right clinical judgment, and I didn't do my provocative testing of the movements, what's the risk? On the slide here, in a normal spine, extension positioning allows compression of the fecal sac. The retral fat pad here is pushed up, along with the ligamental flavum is pushed up with the facets, and it makes the cross-sectional area and the area for the nerve root to come out, where the ganglion is. Also the ganglion. Here's the disc bulging. The extension bulges the disc posteriorly. Also anteriorly does the same thing, by the way. So I'm looking at this. Now, I'm kind of patient. Thank you very much. I really enjoyed having any questions.